So good evening, friends. Welcome to this session of 46th Comprehensive Course on Echocardiography. Today, we are going to have an examination for all the students to look at LV systolic and diastolic function as well as cardiomyopathies. I have received many requests that they will not be able to attend because of Makar Sankranti and some other respected reasons. Friend, it's okay. But once we come down to final assessment, then the people who have attended this question answer sessions and they've attended a complete attendance of more than 70%, they'll be getting a certificate, or else they have to take their examination on a Zoom call where they'll be posted about 10 questions. If they're able to give answers correctly for about 60% of the questions, they'll be getting a certificates. So it's not just a matter of thing like you just say that today is this holiday, tomorrow is that holiday. So every day is a holiday. In fact, Sunday is a holiday. So with these few words, let me move on to this examination today. And I'll be asking questions in a serial-wise fashion. Those people who have attended their questions, if they want, they can leave. And if they want to stay back for a complete session, they are most welcome. So with this, I'm Dr. Rakesh Gupta, who's going to take this question answer session today. And I'll be showing one by one slide and asking the questions. Now, my first question to Dr. Nitin. Nitin, are you there? Nitin?
Yes, sir. Can you hear me, sir?
Yeah, I can hear you very well, Nitin.
Yes.
So my first question to you, Nitin, is there are three pictures which are seen on this image's quality. So can you see my arrows or my hand movements on your screen?
Yes, sir, I can.
Okay. This is identify what is this view is and what is the wall thickening abnormality in this particular view.
So the first image where it is actually pointing says that there is hypokinesia of the wall of the apical segments, especially the lateral apical at the lower point.
You have to see it very carefully. Just don't jump to a conclusion and answers. Just be very careful. It should be in straightforward. It's not that we cannot see that. You have to be very, very careful. And once Dr. Nitin says yes or no, or his answer is correct or right or wrong, then I'll pick up the next person who have raised their hands.
And sir, I also feel that there is a papillary muscle abnormality in the first picture.
No, Nitin, I'm just asking you wall thickening abnormality.
And sir, there is also thickness of the basal segments in the first picture, sir.
Basal segment, which basal segment?
That is the and lateral, that is the basal anterolateral segment, sir.
Are you talking of this segment?
Yes, sir. Correct, sir.
Okay. Anything else?
And also there is, sir, there is an abnormality with the mitral valve. It looks not floppy exactly, but there is an abnormality. Possibly an MR may be coexisting, sir.
All right. Only those people should raise hand which have got a correct answer, or I'll deduct your numbers. So be careful when you start answering your question. You can still withdraw yourself. Whenever there is an abnormality, when you're confirmed about an abnormality, then you should try to attempt the question. So Nitin, I'm sorry, I'm not able to agree with you. I'll move on this question to Rupali. Rupali, want to take this question?
Yes, sir. Yes, sir.
Go ahead.
Sir, first view is four-chamber view, and basal septum is akinetic. Then in two-chamber view,
No, I'm
basal,
not going to two chamber. I'm just asking for four chamber view.
basal septums are akinetic.
Anything else?
And lateral wall, basal lateral wall, sorry, apical lateral wall is hypokinetic. Then
attempt whatever you see correctly. Don't attempt whatever you can't see correctly, Rupali.
Okay. But basal septums are only basal septum. I think it is akinetic because
Perfect.
it's thin and
the basal
akinetic.
septum which is akinetic.
Yes, thin and
very
akinetic.
carefully. This is the only segment which is akinetic.
Yes, sir.
And if you add hyperechoic, thinned out, it'll give you more marks.
Yes, sir.
Okay.
Yeah.
All right. Good attempt, Rupali. We'll hold in over there. We'll come back again. Let's go to Dr. Veerwar Jha.
Yes, sir.
Dr. Veerwar, are you there?
Yes, sir. Present, sir.
Veerwar, tell me about this second segment.
This is, sir, apical two-chamber view.
Be sure what you're saying is.
Sir, apical three-chamber view, sir.
There only one more is left. Apical 2, apical 3 or apical 5?
Apical three-chamber view, sir.
It's not apical 3-chamber view. You cannot make one more attempt.
Two-chamber view, sir.
Which chamber view?
Sir, apical two-chamber view.
No, I don't agree with you that this is apical 2-chamber view. If you say this is apical 2-chamber view, you have not attended my class at all. Okay. Shall you would like to take it again or give it to somebody else?
Sir, give it to somebody else.
All right. So, Dr. Narendra, you would like to take on this question? Dr. Narendra Kumar. No, he's not interested. Anybody else would like to take up this question? Can raise his hand.
Sir, good evening, sir.
Dr.
Am I audible, sir?
Venkatesh.
Hello.
This is
Narendra Kumar, sir.
view.
Dr. Venkatesh, you want to take this question?
Yes,
Sir, apical 5-chamber view, sir. Dr.
this is
Narendra.
apical 5-chamber view, and there is a global hypokinesia.
Wait a minute. One person, one by one. Dr. Venkatesh, you are speaking right now?
Yes,
Yes,
sir.
sir. Dr. Narendra, sir.
Dr. Narendra. Narendra, you are taking this question. This is apical 5-chamber view.
Yes, sir.
I'm sorry, you are wrong. You'll be losing marks out of this.
Sir, because sir, here aortic valves are seen.
Where is the other two chambers?
Sir, it is generally, sir, not showing because this is the zooms part.
This is not zoom view. Apart from aorta, anything else which tells you that this is the part of apical 5-chamber view? I'll give you marks.
The AML and PML position.
Wait a minute. Wait a minute.
Because sir, here only 2 chamber and one aortic valve is only in this view, sir.
Okay. Dr. Mahesh Patsalge.
Yes, sir. The
Go ahead.
first, sir, I can explain, sir. This.
Go ahead.
Yes. So the first video, which
I'm
is
not asking first video is over. Second video.
Okay. The second video is two-chamber view.
Wrong.
Where
Wrong. We'll not go ahead of that. Zero by 5. Anybody else would like to take up this question?
Sir,
Achal?
sir, it is still 4-chamber only. We can see slight amount of aorta in this, but the thing is that because the AML is still is still on the left side,
Achal, you are also
PML is
wrong.
on the right.
Wrong, Achal.
Typical long axis view, sir.
Well, I'll not like to spend more time on this. This view is absolutely a wrong view, whatever it is. Why it's a wrong view? This is possibly a 5-chamber view because we still see a lateral papillary muscle. It cannot be 2-chamber view at all, because if it is 2-chamber view, the inferior wall papillary muscle should be here, not the lateral wall papillary muscle. Only 1% Dr. Narendra was correct to a large extent that it could be a part of 5-chamber view. And this is aorta which appears to be opening up. So the tech who made this view, and he came back, sir, in 2-chamber view, I'm able to see an additional papillary muscle. Got it? So if you happen to see this kind of a view, this view is not a correctly driven view. This is most probably a cut short section of 5-chamber view where they're rotating a probe from 4-chamber to 2-chamber. They have not done it adequately. And on top of that, they opened up the aorta. So this is still lateral wall. We have a papillary muscle. Remember 2 basic things. Whenever you look at a view, always look at a papillary muscle. Lateral wall will have a lateral papillary muscle and the inferior wall will have an inferior papillary muscles. God has not made till date any papillary muscle attached to anterior septum or septum. Is yet in the process to create another few papillary muscle. Got it, everybody? So your first answer should be, sir, this view is wrong. The day we will understand why we are talking of a wall motion abnormalities, itself they'll tell you, look, this is no, it's not correct. All right, let's go to the next person, Dr. Ankit Saini from Panipat. Ankit, are you there? Ankit. No, he's not there. The next one is Dr. Shashank Tuse.
Yes, sir.
Shashank, what is this view is? Look carefully
This is
before you
3
jump and telling me this is view is this. Look very carefully. I'm not showing you the correct things all the times.
Sir, it is 3-chamber view, sir.
Are you sure this is 3-chamber view?
Yes, sir.
Okay. So in this 3-chamber view, what is this wall?
This is lateral wall, sir.
Shashank, we are coming.
Sorry, inferior wall, sir. Inferior wall, sir.
We are coming closer to a finishing of this topic, this session of 46th course. And today you're telling me that is the inferior or anterior wall. In 3-chamber view, this is inferior or anterior wall?
Sorry, septal wall, sir. Septal wall.
Even this is not septum.
This is.
I'm sorry to say this is not septum at all. Shashank, I don't understand that. Are you really studying or you're just attending the lectures? If you can't see what this segment is, how can you make a wall thickening abnormalities? And what is this wall is? If this is anterior or septum or inferior, then what is this wall is? Tell me what is this wall?
This is anterior wall, sir.
I'm sorry. Shashank must read. 0/5. If you can't identify this view, what is this view is, and if it's 3-chamber view, okay, I'll take it for some time. Then this cannot be anterior wall. This cannot be inferior wall. This cannot be other wall, what you said, lateral wall. Dr. Niharika, you like to take this question, Niharika?
Yes, sir.
Tell me what this wall is. What is this view?
Typical 3-chamber view, sir.
Apical 3-chamber view. What is this wall?
Mm.
Shashank, listen carefully now.
Anterior septal.
Anterior septum. Perfect. And what is this wall? Now you be
Inferior
careful.
lateral.
Niharika, what you're saying is
Inferior lateral.
infralateral. Why did you say infralateral?
So there is the papillary muscle.
Correct. So it's not truly a three-chamber view. It's a modified three-chamber view where instead of a posterior wall, we are able to see an inferior wall.
Yes.
Okay. Good attempt,
Yes.
Niharika. So what is the blood supply of this particular wall?
Which one, sir? Inferior, right anterior.
Right
Artery.
coronary artery.
Right coronary.
Good. Good, Niharika. Good attempt. God bless you. You are in Andhra Pradesh, right? Chirola.
Yes, sir.
Shashank, did you get some answer out of this?
No, sir.
Could you understand what these walls are?
Yes. Yes, sir. Yes.
Okay.
Anteroseptal and
So, I'm sorry, Shashank, please read. This will be only in your benefit, not in my benefit.
yes, sir.
All right.
Sorry, sir.
Let's move on to next subject. This question is for Dr. Shivaji Vitoba Malik, Pune. Are you there? Shivaji? Then Dr. Harshvardhan Kuri, Rajasthan. He's not seen at all one number of times.
Sir, I'm present.
Oh, wonderful, Harsh. So,
Good evening, sir.
good evening. Tell me anything other abnormality in this four-chamber view, apart from basal in septum, which is akinetic. Anything else which you see in this four-chamber view?
Sir,
We are
mid-septum is
concerned
also
with wall thickening. We are not concerned with walls at all.
Sorry, sir.
We are concerned with wall thickenings.
Yes, sir. Sir, mid septum is also hypokinetic, sir.
Okay, let's take it. It's not there anyway. Anything else apart from this?
Sir, there is the hypertrophy of the LV on the the lateral anterior lateral end, and there is some amount of non-compaction also, so you can say.
Perfect. This is
Yeah.
what I was looking forward. You should come out. This is some amount of non-compaction which is present in this lateral wall.
Yes, sir. I can see the recesses over there. We
Excellent.
should
The same
we
thing
should
can
put
be
the
seen over
color
here.
and identify the color
Same thing
flow.
seen over here.
Yeah.
So apart from this basal inferior wall, basal septum, this segment shows non-compaction. Excellent, Harshvardhan. You have made my day today.
Okay, thank you, sir.
Let's move on to next. This is what we were looking forward, non-compaction. Now, next question goes to Dr. Pallavi Horo.
Yes, sir.
Pallavi, tell me, what is the approximate ejection fraction? Normal, mildly reduced, moderately reduced, or severely reduced?
So mild to moderate reduction.
Mild to moderate reductions. Very good answer, because your boss cannot say anything. What do you mean by mildly reduced ejection fraction? What is exactly values for mildly reduced ejection fraction, Pallavi?
In males and females, in the male, it is around 52 to 72, and in females 54 to 74. And mild reduction, it is up to 60, and then severely reduced is less than 30%, and 30 to 50% is moderate reduction.
Pallavi, please read it again. The ejection fraction till now, as far male is concerned, is 52 or more. For female is concerned, is 54 or more.
Yes, sir.
Mildly reduced, you go up to 40.
40 to 50, and 30 to
40.
40 is moderate, and severely reduced is less than 30% in both cases.
Right. So what would be the approximate ejection fraction in this patient?
It might be around 40%. around
Okay,
approximately.
I'll take it for you because it's not 40%, it's close to normal. Only one segment which is akinetic is basal inferior
Segments, yes,
basal
sir.
septal segments, and that does not contribute anything to LV significant contractions.
Yes.
So ejection fraction would be almost normal, about 50-55% in this patient.
Okay.
Hello,
No
sir.
problem.
Hello, sir.
Hello.
Yeah, Raj Bolkar, go ahead.
Sir, can we use MAPSE as an indicator for LVEF? We
Yeah,
can
we
see
can
if
use
it is less
MAPSE,
than
but
0.8.
MAPSE is not the correct method of looking at LV functions.
So,
But if MAPSE is less than 0.8, we can see EF is less than 50%.
MAPSE would be like applicable for medial septum and lateral segments. If you put
Yes.
on the lateral segments, you'll find it to be normal. If you put on a medial segment, you'll find it to be abnormal.
Yes, sir.
So that's why MAPSE is just only one segment, like one septum. When
Yes,
we
sir.
talk of ejection fraction, we talk of a global ejection fraction because it's consisting of septum, lateral, anterior and inferior, and interior septum and posterior wall.
Yes, sir.
So as far as MAPSE is concerned, whether on medial or lateral annulus, this is just a gross idea like what kind of ejection fraction what we are dealing with.
Yes, sir.
And it's used majority of time in patients who have got a poor echo windows.
Yes, sir.
And we cannot look at a good ejection fraction in those subset of population.
Yes, sir.
Like in ICU, patient on a prone ventilations. Just get a probe and look at this MAPSE and other factors to give you a rough idea what ejection fraction is.
Yes, sir.
Okay.
Sir, I had a doubt. So,
Yeah.
what about the PML and the sir? What about the Coronary status here? I'm not able to
What is a
appreciate
normal?
the. I'm not able to. I was not able to appreciate.
No, it's normal.
Okay, sir. Thank
Excuse me, sir. So how can we say that EF is 55%?
It's a visual estimation, or else we go for calculation by modified Simpsons.
Hello, sir.
Yeah.
Sir, can we comment about the non-compaction without the contrast study?
Yes, we can do what is non-compaction is? Non-compaction is when the compacted versus non-compacted ratio is 2:1.
Sir.
So my question talking of suspicion of non-compaction is look at this sieve-like pattern over here.
Yes, sir.
And if you want, I can really zoom it up for you. Just give me a second. No, it will not be zoomed. It's a single picture. So this sieve-like pattern, or we look at very carefully, which is seen over here is like suggestive of non-compaction.
Yes, sir.
Pallavi?
Yes, sir.
Need something good knowledge, right?
Yes, sir. Yes.
All right. So at least remember ejection fractions.
Yes, sir. Yes, sir.
Okay. Now next question goes to Achal. Achal, are you there? Yeah, you are there.
Yes, sir. Yes, sir.
Achal, I have given you certain parameter for diastolic function.
Yes.
This parameter is EA ratio is 0.53.
Okay, sir.
E prime is what? 5. Septum is 5, lateral is 5. So in which category this patient would be classified to?
EA ratio is 0.5.
EA ratio is 0.5
So,
and EA ratio is 10.4.
And the E velocity, but say
0.53.
Point-
Normal
0.5.
LV systolic function.
so it is like okay. So A is more than E, but the E particular value per se is almost just 0.5. So if it is actually if it is less than if it is more than 0.5, then anyways it goes to the second category. If it is only A more than E and where E is lesser than 0.5, then it comes to grade 1 diastolic dysfunction. But if it is A more than E with a E of more than 0.5, then we come to the second part of the flow chart, that is grade 2 diastolic dysfunction, in which then we assess by the other 3 parameters as well. So one will be the E by E prime
I'll show you
ratio.
all the parameters now.
Yes, sir.
And these parameters are consisting of normal LV systolic function.
Okay, sir. So with the normal this thing, E by E prime. Yes, sir. It is grade 1 diastolic dysfunction. 0.3. Oh, check. More than 3. Just one second, sir.
Take
The
your
septal,
time.
the LA volume index is also higher. The TR jet velocity is also more than 2.8, and the E by E prime average is it is normal, but you are telling it is normal, no regional wall motion abnormality. So
Regional wall motion abnormalities are there. By ejection fraction is normal.
yes, sir. So we can trust the E by E prime values. That means.
Okay.
Because there is no regional wall motion abnormality. So the thing is that from the very first moment that because the E value is less than 0.5 and E by A is less than 0.8, we go into the category of grade 1 diastolic dysfunction only, even though the other things could be related to other abnormality, the TR velocity and LA volume.
Look, EA ratio.
Yes, EA ratio
is 0.8 or less than that. Then average is 7.25, so it's less than 10. PR tech velocity is less than 2.8, is more than 2.8. LA volume is increased. So we classify them as grade 1 dysfunction with raised LA volume.
Yes, sir.
At least, because TR jet velocity
at least grade 1.
high.
Yes, sir. Yes, sir. Yes, sir. That was my
So
only
it could be
confusion.
between grade 1 and grade 2, but at least grade 1 is definitely there.
Definitely there. Yes, sir.
So we have to look at all these parameters to look for diastolic dysfunction in a normal subjects, right?
Yes, sir.
No, sir. The IVRT, sir, we are.
Ashok, where IVRT will play a role today? After 2016, IVRT is only applicable when we are doing atrial fibrillation, then mitral stenosis, mitral regurgitation, hypertrophic cardiomyopathies, not in a normal subjects or reduced LV systolic functions. Right?
Sir, why don't we call this grade 2 diastolic? Because out of the 3 parameters, 2 are coming positive. We have TR jet more than 2.8 and LA volume is more than 34.
We don't call them as grade 2 because we are dealing with normal LV systolic function, not a deranged. And the table you are trying to use is for deranged LV systolic function.
Okay, sir.
All right. Let's move to one next. Dr. Saurabh Gupta.
Yes,
Saurabh, this is the image of a patient. Tell me, what is the abnormality in this patient?
Sir, first of all, the mid and basal septum is akinetic and there is increased echogenicity and thickened. And there is clearly non-compaction as well. It is seen in the apical lateral and the mid-lateral LV wall. And the dilated LV as well. And the mid part of the left ventricle is also dilated, as seen in dilated cardiomyopathy.
You said mid and basal septum is hyperechoic, akinetic. Right?
Yes.
Then this segment.
Then, sir. So this segment is echogenicity is okay, but there is clearly a thinning out is seen, and the non-compaction which we.
Now, when thinning is there, how can the non-compaction be there?
Sir, non-compaction is there in the apical and the apicolateral walls.
No, it's not there.
Because the endocardium is clearly visible there, the fissures in endocardium.
I hope you understand what is non-compaction is.
Sir, when the ratio of the endocardial thickening and is more than 2 times of the adjacent endocardium, which is hypokinetic.
No. Anyway, this patient has got many hands that have been raised. Sangeeta, you would like to take this question?
Yes, sir. Can I try, sir?
Yeah, go ahead.
So the first one is apical 4th chamber view, and it shows there is a thinning and Echinacea of the apical septum, and there is a reduced contraction, and there is possible hypokinesia of the apical lateral wall in the fourth chamber view.
Sangeeta, I'm sorry, like I could only see one segment which is not contracting over here. The rest of the apex is practically not visible. You look.
Sir, can I try, sir? Sir, can I try? Nitin, sir.
Yeah, Nitin, go ahead.
Sir, there is a sec scene in the apex because it is hypokinetic and also dilated, possibly, sir.
Nitin, my quest of showing this slide is very clear.
There is
I cannot make out anything in the apex. Only segment which can I really say that something is seen in this slide is this apical part of a septum, mid or apical part of the septum, which is thinned out and akinetic. That's all.
Sir, and could there be a clot, sir?
That's what I'm saying. I cannot say what part is abnormal or abnormal. And when we see these kind of things, obviously we always say that this segment is not visualized. Anything could be possible. And once we move on to other segments, look, this segment, anterior septum, and this part of the apex is not seen at all. Right? Let's go to two-chamber view. Even this two-chamber view is, this part is not seen clearly in this two-chamber view. So we have to be very, very specific in talking about wall thickening abnormality.
Parameters for diastolic function.
So we have to be very specific in talking of wall thickening abnormalities. If you can't see, please tell, look, I can't see these wall thickening. Just don't presume what you are trying to say.
Can I ask one thing, sir?
Go ahead, sorry.
Sir, is this the spontaneous echo contrast or the endocardial border in the first image? At the apical and the apical lateral wall?
No. This is like, this looks to be an artifact. What you are saying is spontaneous echo contrast. It's an artifact.
Okay, sir.
Hello, sir.
Yeah.
Sir, can spontaneous echo contrast be present due to mechanical wall?
Mechanical?
Wall. Or mechanical valve, sir.
Yeah, those kind of a different things are present. Mechanical prosthetic valve you're talking about, right?
Yes, sir.
Yeah, those are different things altogether. Those are like bubbles kind of a thing which is seen in mechanical prosthetic valves.
Okay, sir.
All right. Dr. Arnab Mandal. Avinash Solanki.
Hello.
Yeah, Avinash.
Good evening, sir.
Good evening, Avinash. Now, this is a slide of a patient who has got a reduced LV systolic function. Tell me what kind of an diastolic function this patient has got.
Sir, grade 1 diastolic dysfunction.
Okay. Dr. Rajesh Gudade.
Sir, can you hear me?
A little bit.
Sir, here E by ratio is 1.47, which falls between 0.8 to 2. Then the TRZ velocity also more than 2.28. So I think it is a grade 2 diastolic dysfunction, sir.
Okay. Rajesh Gudade says grade 2 diastolic dysfunction. So Dr. Mahesh Patsalge.
Yes, sir. It is grade 2 because E by A ratio is 0.8 to 2. That is 1.47. TR jet velocity is less than 2.8, that is 2.29, and TR gradient is again less than 28. So it fits in grade 2, but I will require this LA volume to just categorize in between this whether yeah, E by E prime is more than 21, more than 14. So in grade 2, it is grade 2 with increased LA pressure, sir.
LA volume is 46 ml.
Yeah, so it is more than 34. So normal LA volume is 34. That is so all three parameters, that is LA volume more than 34 is there. E by E prime is more than 14, and again we have seen the previous one, TR jet is lesser actually. So it, yeah.
So this was reduced ejection fraction.
Yeah.
EA ratio ranges between 0.8 to 2.
8 to 2. Yes, sir.
Right?
Yes.
And E velocity was not less than 0.5. It was more than it's classified into this particular category.
Yes, sir.
Average E2 prime is more than 14. TR jet velocity was
2.1, sir, there.
2.1, it's not there.
Yeah.
LA volume is increased 46
Yeah.
ml. So 2 out of 3 are positive in this
Positive.
patient.
So it is
So
increased
it
LA
belongs
pressure.
to grade 2 diastolic dysfunction with raised LA pressure.
Yes, sir.
That's how we do this in a regular subjects. So we have to identify LV function, and based after identification of LV function, we look at whether it's normal or deranged, and then we classify them accordingly to various categories. Right?
Yes, sir. Yes.
Good. I hope everybody accept this answer.
Yes, sir.
Yes, sir.
All right. Dr. Sangeeta Chaudhary.
Yes, sir.
Go ahead. Sangeeta, just tell me wall thickening abnormalities of this patient.
Yes, sir. Sir, in the apical fourth chamber view, there is thinning and echinacea of the apical septum, and there is hypokinesia of the apical lateral wall also, sir.
Okay.
In the apical fourth chamber. Next is apical
Two chamber view.
In the apical two chamber view, we can see that sir, actually, since in the apical fourth chamber there is involvement of the apical septum and apical lateral wall, I should be looking for the LED territories in other views also.
Okay.
So in the apical two chamber, it I'm not very sure, but there may be there seems to be reduced wall thickening in the mid anterior wall. And in the apical three chamber view, there is again thinning and echinacea of the anterior septum, apical portion of the apical and mid portion of the anterior septum.
Okay, fine. You are reasonably good. I'm not saying that you are not bad. You are very good. Only thing is you are not able to identify in two chamber view. Ashok, you like to take up this rest of the answer question?
Yes, sir.
Ashok Yadav.
Yes, sir.
Oh, sorry, sir.
What is the wall motion abnormality in two chamber view?
Which chamber view, sir?
Two chamber view.
Yeah. Apical anterior, mid anterior are hypokinetic.
Okay. And
the apical inferior also looks hypokinetic.
okay. So looking at all views, this, and this, where do you classify this abnormality? RCA, LAD, or circumflex?
LAD,
Sir, LAD. LAD.
LAD, and
Perfect, LAD. Now my next
Yes,
question
sir.
is, Ashok, to you is, this is old infarct or a new infarct? If it is old, why? New, why? Ashok, go ahead. Wait.
Can you repeat? Can you repeat, sir?
Is it old infarct, new infarct? And why? Okay, fine. Dr. Birata Debarama, you can give the answer. Are you there, Dr. Birata?
Yes, sir. It seems to be old infarct, sir.
Why is old infarct? Why not new?
Sir, can I see, sir?
Sir,
Wait a minute, wait a minute. Ashok, you want to say something? Why old infarct, Birata? I say it's acute infarct, immediate infarct. When I was taking classes, I was telling you why. When Birata, you like to take up this question? Because you said old infarct. I said, okay, it's old infarct. Why it's old infarct? Why not new infarct?
Sir, the exact answer I don't know, sir.
Okay, Venkatesh Goda.
Sir, can I try?
Dr. Subhash.
Dr.
Yes, sir.
Prasanna.
This is old one because the wall is thinned out. It's not.
Good attempt. The endocardial thickness is lost completely.
Thickness is not there.
So it's a whole infarct.
Yes.
And Subhash, can you tell me this is akinetic, hypokinetic, or aneurysmal?
This is akinetic.
Sir, Dr. Prasenjit, sir.
Prasenjit, go ahead.
It looks aneurysmal, sir.
It looks aneurysmal. Look in this segment. Persistent dilatation during diastole.
Correct.
So there is suspicion of that. That looks to be aneurysmal. So I'll take it for granted that's a good answer. That's akinetic. I don't deny about it. But at one time, I'll have to think over that. Could this be aneurysmal? Or this is a true aneurysm? Right? Great.
Sir, could it also be tethering effect, sir?
No. Dr. Piyush Panda from Gondia. Piyush, are you there? Not this one. Dr. Pankaj Mishra, Bhubaneswar.
Yes, sir.
Pankaj, tell me about this particular segment, second one. What is the abnormality of this segment?
Sir, this is a apical three-chamber view showing
What is showing?
that is showing hypokinesia in the basal septum.
Where is septum? In three-chamber view, where is septum? What is this wall?
This is a septal, sir, anterseptal.
Septum, anterior septum or posterior septum?
Anterseptum, sir.
Anterior septum. And what is this wall?
Sir, this is posterior wall, sir.
Okay. So where is the hypokinesia?
Basal septum, sir. I think so. I'm not sure. then it is hypokinesia around apical septum.
Apical anterior septum.
Anterior
Do we
septum,
have
right, sir.
something like apical anterior septum?
Right, sir.
We don't have anything like apical anterior segment.
Sir.
What are the segments of this three-chamber view?
This
What is
is
this segment?
This is mid anterior septum,
No.
basal anterior
This-
septum, then mid anterior septum, then apical anterior septum.
There is nothing like apical anterior septum. What is this segment?
This is basal posterior wall, sir.
This?
Mid posterior wall.
What is this?
Apical posterior wall.
I'm sorry, Pankaj, you are not attending classes. When we classify the wall motion abnormalities in three-chamber view, we only recognize mid-anterior septum, basal anterior septum, basal posterior wall, mid-posterior wall. We do not have apical posterior wall, apical anterior septum. I'm really sorry to say that you're not attending the classes properly because this was basics when we started talking about all this. Right?
Right, sir. Right, sir.
And if you look at this very carefully, what do you see a wall motion abnormality in this patient, in this segment?
This is hypokinetic, sir.
Hypokinetic what? You have to say mid-anterior septum or basal anterior septum or mid-anterior septum.
Mid-anterior septum, sir.
Mid-anterior septum is hypokinetic. Okay. And basal? Normal contracting, hypocontracting. All right.
Hypokinetic, sir. I'm not sure.
Dr. Ajit Balasab Dangle, Pune. Are you there, Ajit? Dr. Kiran Vasantrao Birari, Nasik. Dr. Rota Singh Kalsi, Gurdaspur.
Yes. Good evening, sir.
Good evening, Rotas. Tell me what is wall thickening abnormality of these segments.
Sir, this three-chamber view, sir. We can see there is a hypokinesia of the apical anterior and mid anterior septum, sir.
Okay.
And also the apical area, sir. So apical anterior and mid anterior septum, sir.
Will you like to comment on these segments? Anything abnormal you see in this? Ratan is very simple, like many people are raising their hands. Mid-anterior septum is almost akinetic. LV
Yes,
appears to be dilated and there is evidence of a spongy myocardium or a non-compaction of LV.
Yes, sir.
And the word itself give you a look at the top is postpartum cardiomyopathy.
Okay. Yes, sir.
So you're not able to see this. Even the postpartum cardiomyopathy, you can't see like these people who presents with dilated cardiomyopathy or patchy myocarditis.
Okay, sir. Yes, sir.
Okay?
Yes, sir.
All right. Dr. Sandeep Kumar from Delhi. Sandeep, you have just joined. Sandeep? Are you there, Sandeep? Dr. Prakhar Gupta, Firozabad.
Yes, sir, I am here, but my screen is switched off somehow, so I will be attending from this device.
You are Prakhar Gupta or?
No, sir, we are attending with each other. So. My
No,
screen,
what's your name? Sandeep or Prakhar Gupta?
Sir Gupta.
Okay. You can't see anything, Prakhar?
No, not on my screen, but I'm sitting with sir, so I'm looking at his screen.
So you can see the screen, right?
Yes, yes, sir.
So tell me the abnormality on this segment. What is this view and what is the abnormality, Prakhar, in this?
Sir, this view is apical 3-chamber view.
Okay.
And this is the anterior septal wall.
This is anterior septum?
No, sir, the other one.
Other one is anterior septum. Okay. What is the abnormality in this view, Prakhar?
Hypokinesia of the apical anterior septum wall.
Apical anterior septum. We just discussed a few minutes back. There is nothing like apical anterior septum.
Global hypokinesia, I think.
Where is global hypokinesia, man? I'm afraid you just can't copy. This is a mirror image of the same patient just kept over here and here. I've just increased the zoom gains. Just increased the 2D gains. Nothing more than that I've done in this patient. You can't replicate the answer of this image. I'm sorry, Prakhar. I don't think you are serious in attending any of the classes. Majority of time you were absent. Out of last 5 classes, only 2 you were present. How can you give an answer? Because complete session, you have already attended only 2 classes. How can you give an answer? I'm really sorry, Prakhar. I don't know what to say. Dr. Chitranjan Thattai from Cuttack. Are you there, Chitranjan? Dr. Sarada Prasanna Sahu, Cuttack. Then Dr. Subhash Chandra from Vijayanagar, Agra. Dr. Subhash?
Yes, sir.
Dr. Subhash has been absent for last 2 classes consistently.
No, I was present, sir. I was present. Just possible there is some discrepancy or some problem.
Discrepancy in attendance or discrepancy in your presence?
No, I was present, sir.
Okay, Dr. Subhash, tell me about this view. What is the abnormality in this wall thickening abnormalities?
Generalized hypokinesia more in apical segments.
And
this is tissue Doppler.
This is not tissue Doppler. I'm sorry to say that. I'm not very happy today, Sir Subhash, like looking at the answers I'm getting from every one of you. I'm not really happy at all. Is it this tissue Doppler? These are B scan colors. They are not tissue Dopplers.
Okay. Could it be, I think apical segments are more hypokinetic than the basal ones.
Apical segments are akinetic, man. Apical half of inferior wall, apical half of anterior wall is akinetic. It's almost thinned out. And apart from that, the basal septum is almost so akinetic. Basal inferior wall is also akinetic. This happened in type 3 LAD when the LAD wraps around the complete our LV apex. And that's what happens. It's a proximal LAD lesion, not proximal mid LAD lesion.
Yeah, that's what I said, sir. Almost all the segments in the apical 4th chamber, they are involved. They are hypokinetic. So it has to be
hypokinetic. Dr. Subhash, still I'm saying the same thing. These are akinetic segment.
Okay.
Hypo would be less contracting. These are akinetic segments which are thinned out from a long-standing infarcts.
I got it.
Look at the basal inferior wall. This is almost aneurysmal.
Yeah, I got it, sir. Make it sure, sir, I was present in both the previous classes. And
I don't know why I marked you absent because I've been taking regular attendance. But
sir, because my mic was, there was some problem with my phone, and that's why it happened. And I did ask one question last time, and I don't know how could I be marked as absent.
Anyway, let's move on to next person. Dr. Sofirul Islam from Assam. Sofirul Islam from Assam. Are you there, Dr. Islam? Dr. Pranjal Prakash Jagtap Nasik. Dr. Pranjal, are you
Yes,
there?
sir. Yes, sir. Yes, sir.
Okay, tell me what is the abnormality in this segment, in this slide?
So this is a apical four-chamber view. There is so I don't think there is any abnormality in this.
Perfect, Pranjal. God bless you. You have made my day today for the first time.
Thank you, sir.
This is a follow-up of the same patient who had cardiomyopathy. And we did follow up after some time. And all these wall motion novelty which you saw previously, they had disappeared.
Okay, sir.
Great. I'll ask you one more, Pranjal.
Yes,
and
sir.
the initial bonus.
Yes, sir.
Same patient, normal LV systolic function.
Yes, sir.
Look, all three images, the same patients.
Yes, sir.
No MR now?
Mm,
No, the MR has disappeared, Pranjal.
yes, sir.
Completely
Yes,
MR
sir.
has disappeared.
Yes, sir.
Only trivial MR is present. Now, just go to this first clip. Just tell me one single abnormality, rest I'll ask from other people.
Mm,
You can look at all three views and tell me
yes, sir.
one single abnormality. I'm not going to ask you more than that, Pranjal.
Um, mm, s- sorry. Sorry. Is there LV compaction?
There's nothing like compaction in this. Any wall thickness abnormality in this patient over here?
Yes, sir. There is a wall thickening of the mid inferoseptum, sir.
Mid infroseptal. Is it this mid infroseptal over here or here?
No, sir. The previous one you showed. Yes, sir.
Here?
This one. Yes, sir.
No. This is thickened sigmoid septum, which is seen over here and seen over here.
Okay, sir.
Anyway, Pranjal, we'll come to that later on. Now,
Yes.
Dr. Deepak Suman from Rajasthan. Deepak, are you there? Dr. Rupali Sawant?
Sir, in
Rupali?
first view, sir, first view in four chamber LA is dilated. In two chamber view, inferior wall is severely hypokinetic.
Look, Rupali, you are a good student. There's nothing like severe, nothing like mild or moderate. Either is hypokinetic, akinetic, dyskinetic, or aneurysmal. The word is when we talk of mild, moderate, severe is when we are not sure by ourselves what we are telling somebody.
Okay.
So if I'm saying severely hypokinetic, it means something different. If I say akinetic, it means something different. So this wall is hypokinetic, akinetic, or dyskinetic, or aneurysmal. You have to say that.
Aneurysmal basal inferior.
Basal inferior is aneurysmal. True. Is almost akinetic and aneurysmal.
Yeah.
Look at the segments over here. This is stark contrast outside. And when they become aneurysmal, it means they are almost dead.
Yes.
When we talk of hypokinetic, it means the blood supply, it means the segments are possibly viable. When we say akinetic, it means possibly they are dead. So if somebody has presents with this kind of a segment, and if I do a coronary artery supply, do an angiogram for RCA, and I see RCA is 99% blocked, whatever I do, I'm not going to revascularize this segment. I'm not going to restore this blood segment. Sorry, make it viable. I always say in Hindi, अगर आप भूखे आदमी को खाना दोगे तो खड़ा हो जाएगा, अगर आप डेड आदमी को खाना दोगे तो नहीं खड़ा होगा. This is dead man. Right?
Yes.
Identification is good. So next time you are a good student. Like I could pick up you one of those. So you're a good student. Must say hypo, a,
Aneurysmal.
dyskinetic or aneurysmal. All right.
Yes.
Good pickup. So let's go to, you are the one who has scored almost double marks today.
Thank you, sir.
Sir, is LA dilated in this?
LA, I'm not going to comment on LA dilated because I'm talking of wall thickening abnormalities. I know I'm going to go to Dr. Archana Kishore Sanalkar. Archana, are you there?
Yes, sir.
Archana, tell me wall thickening abnormality in this first view. Do you any see wall thickening abnormality, Archana, in this view? Yes or no?
Yes, sir.
Where are you, Archana, right now? On the screen, or you're lost somewhere?
Sir, I'm on the screen, sir.
Correct. Tell me, sir, any wall thickening abnormality in this view? Yes or no? All right. In this view, Archana?
Basal, sir.
Basal what?
Oh. Sir.
Archana, where are you located in Mumbai? Which
Yes.
hospital do you work for?
Sir, I'm just 2 weeks back, I've joined Reliance HN, sir.
Okay.
Before I'm working with Global.
Okay.
It's-
Archana, you need to understand wall thickening abnormalities, spend more time on your wall thickening abnormalities. I'll be asking this question to somebody else and I'll answer you also. Dr. Madhurima Datta, Silchar. Dr. Madhurima, are you there? Dr. Mahesh Padsalge?
Yes, sir.
Tell me
So in-
what.
Yeah, first 4-chamber view, I am seeing basal septum is akinetic, but otherwise all other walls are moving well. And in 3-chamber view, I think 3-chamber view there is no wall motion abnormality which has been seen. In 2-chamber view, we have again basal inferior wall is aneurysmally akinetic. And in last 4-chamber view, mild trivial MR is seen.
Okay.
But
Dr.
this seems
Bhagat.
to be RCA infarct to me actually, because it is the territory which is been supplied is RCA.
All right. Now, all of you, right from Dr. Archana, Madhurima Datta is not there, Mahesh Salge, and I'll ask this question from Bhagat, Vibhusha, Vishwanath, Navi Mumbai.
Yes, sir. Yes, sir.
Tell me wall motion abnormality, Vibhusha.
Sir, in basal septum and basal inferior.
Okay. That's all?
Yes, sir. Yes, sir.
No, all of you are not right. Now I'll tell you why. I thought all of you have been reading. Now concentrate on this segment. Concentrate on this segment. Concentrate over here, and concentrate in the mid segment. Similarly, concentrate on here. Basal lateral, basal posterior, they are not thickening at all. Look at the thickening of this segment, look at the thickening of this segment, and look at the thickening of this segment. Look at it over here. And the clue was already there with you. Now look at this. Once I tell you, look at this segment. Is it thickening? This part is not thickening at all. This part is not thickening at all. Just focus on that particular segment. You have to go segment by segment to talk of wall thickening abnormalities. If you happen to compare this segment with this segment, look, this is thickening and this is not thickening. This is not thickening, this is thickening. So this is definitely RCA or circumflex, depending on whatever the blood supply of the artery is. But this is almost aneurysmal, and these are relatively hypokinetic or hypokinetic, I'll say rather. And that's only makes a lot of difference. If I have to revascularize this segment, I'll not be able to do it. But certainly if I'm asked to revascularize, definitely I'll try to do this revascularization. So I'm going to be very, very specific what you're trying to say. All right. Dr. Dheeraj Kumar Singh, Delhi. Dheeraj, are you there? Dr. Sanjeev Mathur from Jaipur. Sanjeev?
Yes, sir.
Tell me anything wall motion abnormality in this patient.
The first is the four-chamber view.
Right.
I think it's the apical segment as well. It is contracting well, but it's a little bit thinned out, the apical segment. That's what I could say. I
So
could be
there's no
wrong.
wall
though.
thickening abnormality in this patient at all. Where is the wall thickening abnormalities?
Okay, yeah, then I agree.
All right. Bonus question for you. Tell me the wall thickening abnormality.
This one I can say I don't see any thinning out portion. It's a three-chamber view.
There is no thickening of wall motion abnormality over. What is abnormal in this patient? Spend time, Sanjeev.
Sir, can I try?
Dr. Mohammed Iqbal.
Yes, sir. There is some extra beat, maybe some extra systole or something. Otherwise, no.
Okay, it's not true. Dr. Niranjan Agarwal from Bilai. Niranjan, are you there? Dr. Bhimraya D, Bangalore. Dr. Bhimraya.
Sir, is it?
Rajesh Gudade. And last, if not, then I'll ask you questions. Rahul Kumar from Delhi. Absent. All right. So
The patient is in
we
atrial
asked from-
fibrillation.
just a minute. We asked from Anchal.
May I say something, sir?
Identify yourself.
Dr. Ojha, sir.
Yeah, oh yeah, go ahead.
Hyperkinetic it appears.
Sir, I would like to answer, please.
Dr. Prasenjit, sir.
Prasenjit, go ahead.
The tachycardia mostly AF, sir.
All right.
Yes, sir, tachycardia.
Tachycardia along with ventricular premature contraction can be appreciated in between.
Look, after listening your question answer, this image is
Sir, I will
also
answer.
getting
Sir,
more
sir, let me
tachycardia.
answer.
Is there.
Sir, can I try?
Septal motion.
See the double.
AF with fast ventricular rates.
Sir, there is
It is caudal crossing is looking, sir.
Okay.
Sir, Sam is
Look,
there.
this
Sam,
segment-
sir. This is Nitin. Sam.
One by
Sam,
one,
sir,
one by
Nitin.
one, one by one. There's no Sam. There's no tachycardia. Heart rate is 108. Tachycardia is there, but there's no atrial fibrillation. Achal, you want to say something?
VPC. So tachycardia with VPC.
Leave it.
Probably.
Rupali?
Sir, it's LBBB or RBBB jerky septal
Perfect,
motion.
Rupali. God bless you.
Thank you, sir.
This is classical left bundle branch block. This is not, look at the ECG gating is already there. How can you say it's VPCs? This image is so characteristic of LBB. Now look at this over here, septum. There's no extra beat out here. Only septum is jerky. Rupali, by the way, where are you working?
Sir, Reliance HN Hospital, sir.
Mumbai?
Mumbai.
Okay, good. Great pickup, Rupali. Look at this septal contraction over here. You can see 3 beakings out here. And look at the posterior wall, normal. And when these people, they present with LBB and you look at the wall thickening abnormalities, majority of people, they give a wrong answer because you have to decide whether this patient has got associated coronary artery disease or not. So my next question to Dr. Karthikeyan. Is there Dr. Karthikeyan over here? He is absent. Dr. Ravi Gupta? Dr. Subhash Chandra from Mohali, Punjab. Dr. Khushpreet Singh? Dr. Umesh Ojha, Jharkhand. Umesh, are you there, right?
Yes, sir.
Tell me, Umesh, if this patient has got anterior MI or not. This is patient is presented with LBB, the acute onset chest pain LBB. Whether this patient has got acute anterior MI or not.
This could be, sir.
So what you like to do? You like to thrombolize or take it for angiogram?
Thrombolize.
All right. Dr. Amit Vikram from Munger. Rashiri Karat. Are you there, Dr. Rashiri? Dr. Raj Rajinder Borkar.
Yes, sir.
Tell me whether this patient has got anterior MI or not.
So could be, sir, the heart rate is fast, so might not be able to
Heart rate
convey.
has nothing to do with the acute anterior MI. If I have a bradycardia, does it mean that I've got a no MI?
No, sir.
Then?
So yes, possible.
Patient presents you with acute LBB.
Yes,
and
sir.
these are the few images for echocardiography. One I showed 3-chamber view, then I showed you 4-chamber view,
Yeah.
and then I showed you 2-chamber view. And this is
Yes, sir. Yes, sir.
so you think that this patient has got acute anterior MI, right?
Yes, sir.
Dr. Swapnil Datta? Dr.
Sir,
Swapnil,
it
are you
can,
there?
sir, yes, sir, yes, sir. Sir, it can be a dyskinesia.
No.
No, sir. Then we can
Then we
consider
would-
anterior. Then we can consider, sir, anterior wall MI for this.
Everybody's answer is wrong. Anybody would like to try this question?
Sir, is there hypokinesia?
Nitin, there is no hypokinesia.
Sir, it's some paradoxical septum, like.
We only see a paradoxical septum. We did not see any wall thickening abnormalities. So am I or no am I?
Sir, maybe am I in acute LBBB? My patient is this am I equivalent? His patient is has symptoms and present to LBBB, so it is am I equivalent?
Okay. So I'm going to now tell you why this is not MI.
Sir, is it that same LBBB, sir?
Same LBB.
Same LBBB, right?
This is not MI. Suppose this is anterior wall MI. What would be the wall thickening abnormalities?
It is
anterior wall, inferior wall, septum, lateral wall, apex, right?
Yes, sir.
Lateral walls.
Correct. So septum is jerky. That is because of LBB. But what happens to anterior wall? Anterior wall is normally contracted. If you see associated anterior wall, which is hypokinetic, then you think of anterior wall MIs. And there's no associated anterior wall hypokinesis, then it's a pure LBB without any anterior wall MI. Look very carefully. I go back and explain you again. LBB will affect what? Septum. It will not affect lateral wall. Correct? Lateral wall is normally contracting. Then LBB will affect septum. It will not affect anterior wall. Whole of the anterior wall is supplied by LAD. Look at the thickening of anterior wall. So this patient was just a diabetic with no anterior wall MI, now presented with acute LBB. And when we did a wall thickening abnormality, there was LBB. When we took him for angiogram, it was normal. Right? And these things are very commonly seen nowadays in diabetic populations. Okay. Let me just switch on gears. You people have to read a lot. Lot means a lot. I'm not going to blame you all. This is okay. This is fine. It's reasonably okay at your level, but you have to read a lot. Okay. My question goes to Dr. Parveen Kumar from Danapur, Patna. Parveen, are you there? Dr. Prashant Pandey from Varanasi. Prashant,
Yes, sir.
are you there, Prashant?
Yes, sir.
Okay, tell me the abnormality in this patient.
This seems to be contracting fine.
Now we have shifted gears from LV function, systolic, diastolic to cardiomyopathies.
So this is normal contractility.
Abnormality. Now you can see the abnormality better.
Yes, sir.
What is the abnormality?
RV cavity is completely, sir, it's obliterated.
Pardon?
So the RV cavity is completely obliterated, and
No.
the hypokinesia is there in.
There's no hypokinesia. Dr. Nathan, you want to try?
The apical portion is thickened.
Sir, it is the obliteration of the apexes, sir.
Apical hypertrophy.
Apical hypertrophy, sir.
Correct. All right. Next question goes to Dr. That was Dr. Prashant Pandey, right?
Yes, sir, Dr. Prashant.
Dr. Ravi Kumar Singh from Bihar. Ravi, are you there? Dr. Ankit Agarwal, Bareilly. Ankit? Everybody's enjoying Makar Sankranti except you and us. Dr.
Sir,
Ravi Nilkant Patil. Dr. Sanika Sachin Kadam.
Yes, sir.
Sanika, tell me, don't disappoint me this time, okay? Tell me what is abnormal in this. This is variety of a cardiomyopathy, Sanika.
Yes, sir, it looks like a dilated cardiomyopathy
Good.
with LV and LA dilated.
Okay. Anything else, Sanika?
So apex, LV apex looks spongy. I'm not sure, sir.
All right. I've zoomed up for you, Sanika.
So there is a clot at LV apical level.
There is no clot.
Sorry.
अरे अरे भाई बाद में लड़ लेना थोड़ा माइक साइलेंट कर लो Very good depiction, Sanika.
Sorry, sir.
Tell me something very important in this patient.
There is a tuberculation present.
Tuberculation present where?
Tuberculation present in the apical anterior, apical lateral, apex apical lateral side, sir.
What are these?
Even RV side also, apical RV level also.
So what are these? Many people, they're trying to raise their hands,
So this is type of sarcoidosis or anything. I'm sorry.
All right. Somebody who has not answered this question. Pallavi, you want to try?
Yes, sir. So it is a dilated cardiomyopathy with
mid LV cavity is dilated, and non-coaptation of LV at the apex, sir. And at the right ventricle.
Correct. This is non-compaction, not coaptation, non-compaction of RV.
RV. Yeah.
You cannot have a better slide than this for a non-compaction of RV. So when you happen to see this kind of a picture, when LV and RV, they are dilated and the evidence of bilateral non-compactions.
Okay.
Very rare phenomena. Like we do not see this kind of picture very commonly. All right, good attempt.
Sir, here can we say there is apical thinning and aneurysm with it?
No, there is no apical thinning. Aneurysmal would be something different. Aneurysmal, you have to have a dilatation.
Yeah.
Apex is smaller, mid segments are dilated.
Sir, it looks something in organized thrombus-like thing in apex.
This is not organized thrombus. Very carefully, this is an accessory band in the apex. And this is artifact.
Okay, sir.
All right, let's go to the next picture. This goes to Dr. Anuj Kumar from Devgarh, Jharkhand.
Yes, sir.
Tell me, Anuj, what's abnormal in this? You are lucky, man. You are lucky because you are getting something which is seen earlier.
Sir, it is a three-chamber view, sir. First image with hypertrophy at the apex and the anterior septum level, sir. With segments of non-compaction.
Segment of?
Sir, trabeculations are seen in the apex and the
What
septum.
is this? This is known as what?
Sir.
This is a non-compaction.
Non-compaction, yes.
There is no hypertrophy, man.
Sir, trabeculations are non-compact.
This is a classical example of non-compaction, where the non-compacted segment they present like a hypertrophy.
Yes, it is non-compact.
Segment is
Yes.
over here.
I just missed
This
that
is
word.
the
Sir. Sorry,
non-compacted segments, and they are very clearly seen over here when the blood.
Yes, sir. Blood flow is seen in the trabeculations.
So it's not hypertrophy. It's a
Yes, sir. Sorry, sir.
classical
Actually, I just
example.
missed that the word said non-compaction.
All right, good. Good attempt. Okay. Dr. Deepak Kumar from Ghaziabad.
Yes, sir.
Deepak, tell me what is the abnormality in this slide?
In this picture, E is bigger than A. A is almost absent, sir. And MR is present in second picture.
MR is only mild MR is present. What is the abnormality in this slide, Deepak?
So it can be restrictive type of filling because E by
It
A
is
more than
restrictive.
2.
I agreed. You get 50% marks, that is restrictive filling pattern. What these two slides are telling you?
LA and RA are dilated, sir.
Correct. And LV and RV?
Sir, normal.
LV and RV are normal. If LA and RV
Normal.
they are dilated, LV, RV is normal, then what is this?
Restrictive cardiomyopathy.
Why atrial enlargement in the presence of normal LV, RV? And this is a classical
can be
feature of
due to
restrictive
air-
cardiomyopathy.
Restrictive cardiomyopathy.
Great, good attempt. So Niharika, another good chance to attempt more marks. Are you there, Niharika? Then Dr. Vivek Dwivedi from Loni. Vivek? Narendra Sharma? Dr. Narendra, you are there already.
Yes, sir.
Attempt.
There is some infiltration in the sir, it's a force and filtration in the sir, basal interlateral wall.
Narendra, there is nothing like infiltration when we look for echocardiography. What is this seen in this over here?
Clot.
Thrombus or a clot, correct? So when we have some thrombus or clot, what do you expect in the LV cavity? Wall thickening abnormalities.
And if the aneurysm.
Not aneurysm.
Aneurysm in the sir in the any
Not
walls.
aneurysm. Iqbal,
Sir, LV cavity is dilated.
LV is dilated.
Yes, sir. And there is a hypokinesia and the septal thinning. So this is dilated cardiomyopathy with LV
This is a
thrombus.
dilated cardiomyopathy, and this is all thrombus occupied in dilated cardiomyopathy.
Yes, sir.
Is a very rare picture when almost 70 to 80% of LV cavity was occupied by thrombus.
Sir, how this patient's
Classical case of
almost-
this is classical case of DCM with normal coronaries, and we tried a complete medical therapy, no response. Then we did a CRT therapy, no response.
Sir, what did you do with this thrombus? Anticoagulant?
Anticoagulants. But we lost this patient, unfortunately.
Sir, why is the ECG abnormal, sir? It looks like arrhythmogenic RV or
Arrhythmogenic
something like
RV is different. I'll come to arrhythmogenic RV in a couple of minutes.
Sir, ECG looks a bit abnormal there. I was thinking of ST elevation.
LBB.
Okay, thank you.
Is it possible to remove such a large thrombus with?
Yeah, we do. We do embolectomies. We
Vertical.
try to remove the thrombectomies. We try to do this because there are very high potential of migrating into systemic circulation.
Yes, sir.
Dr. Devendra Pratap Yadav, Varanasi. Dr. Yadav?
Yes, sir.
Oh, good. Yadav, tell me what is abnormality in this patient? Dr. Devendra Pratap Yadav, Varanasi. Ashok?
Yes, sir.
I'm asking for Dr. Devendra.
Yes, sir.
Tell me what is abnormal in this patient? Please tell Devendra. All right. Dr. Iqbal Mahmood, Dhaka. Iqbal, are you there? I saw you were there.
Yes, sir. I am here, sir. I think, sir, it's a apical three-chamber view with normal RV contraction and wall thickness.
Perfect normal RV, LV contraction, but something
Yes, sir.
wrong with this thing.
Sir, the this wall look like some haziness, but I think it's artifact or something. It's not look any.
LV function is normal. Something to do with more of this.
The surrounding is something.
Forget
there.
about surrounding. Look at the cavity itself. Okay. Give me a
Cavity.
clue. Mitral valve.
Yeah, it's quads
Sir, it's a
crossing
little
and
Sam, no, sir, it's a some annulus.
Yes, Sam
What is
present,
it
sir.
thickening, but
Sam. Systolic entry motion of and metal.
we can see more.
There is no systolic entry motion of the mitral valve. You are close by.
This
quads are crossing, sir. Quads are crossing.
This is caudal SAM.
Okay, sir.
Look at this cord, it's just getting into LVOT every time. This is caudal SAM. All right. Dr. Shadab Raja.
Sir,
Delhi.
good evening, sir.
Good evening. Shadab, you have to speak a little louder and stronger, you know. Like
Yes,
Tell me what is abnormality in this patient?
Sir, this is the Black's view, and this septum is thickened, sir. Is how come this kind of, sir?
How come?
Yes, sir.
How come or how come?
How come, sir?
Where is how come, man? There is no turbulence at LVOT, man. There is no dynamic
Yes,
LVOT obstruction.
yes,
That's why
sir,
I
yes.
asked you, is this how come or how come?
This, yes, sir, yes, because this septum is not thicker than this
Septum is thickened.
valve.
Look at the septal thickness, 18 millimeter. Posterior
Yes,
wall is
yes.
23, just
Yes.
16. So there is a
Yes.
septal and posterior wall hypertrophy. Septal and posterior
Hypertrophy.
hypertrophy. There is no
Yes,
MR,
sir.
there is no turbulence.
Yes, sir.
Then what it is?
This this hypertrophy, sir. This is not how come, sir.
This is hypertrophic. What? Hypertrophic cardiomyopathy.
Cardiomyopathy, sir.
Non-obstructive hypertrophic cardiomyopathy.
Yes, non-obstructive.
Sir, there are some small pericardial effusion, like, sir.
Small pericardial effusion over here.
But yes, sir.
It is seen as systole, not in diastole.
Sir, in diastole also posterior wall a little. Okay, sir. Fine.
Hardly any. All right. Let's go to the next question. We are going to ask this question again. All right, good. Dr. Anuj Jain, Khargaon, Madhya Pradesh. Anuj. Dr. Aarti Jadhav, Mumbai. Aarti, are you there? Santosh Kumar from Bardhaman, West Bengal. Oh my God, everybody is absent today. Dr. Sunita Kaul, Gurgaon, FMRI. Dr. Paresh Alwani, Nasik. I'm so sorry. Dr. Pasanjit Pandey.
Yes, sir.
Go ahead. Thank
Sir,
you.
this is some seems like some infiltrative cardiomyopathy area,
Okay.
hypertrophic muscle, sir.
Okay.
And the increased echogenicity of the interventricular septum in general, sir.
Great.
And
what
there
it
is
could
no LV dysfunction as such, sir.
So what it could be?
Most probably amyloidosis, sir.
Excellent. Everything is thickened and brightened.
Yes, sir.
Look at the valves, look at the walls.
Sir.
And there's a small pericardial effusion, poor prognostics for amyloidosis.
Yes, sir.
So this picture is very, very classical of amyloidosis.
And sir, if you see to the ECG gating, there is a very small complex. It's also
it's a small complex. There will not be SCT wave changes significantly as we see in hypertrophic cardiomyopathies.
Yes, sir.
Wonderful. Good attempt. I'm really great. You did a perfect job, Dr. Prasenjit. Okay, next question.
Thank you, sir.
Dr. Sheetal Bodke.
Yes, sir.
Sheetal, tell me what is the abnormality in this slide?
Sir, both the atria, they appear dilated, sir. And there is presence of MR and TR. TR is torrential, it is torrential TR, sir.
What is torrential TR, Sheetal?
Sir, it is depending upon the size of the defect, sir.
Size of the vena contractor, not defect, vena contractor. And
Yes,
size of the vena contractor is how much when we say is torrential?
More than 14 mm, sir.
Okay. So
So
what
it
do
is
you think this
severe
patient?
TR. We cannot say whether torrential or severe, but it looks like severe TR, sir.
There are 5 varieties of TR is present: mild, moderate, severe, massive, and torrential. Okay. The cutoff is 0 to 3, 3 to 7, 7 to 14, 14 to 21, and more than 21.
Yes,
Anyway,
sir.
looking at all this picture, what do you think this patient is suffering from?
So dilated cardiomyopathy with bilateral.
LA is dilated, RA is dilated, LV is normal systolic function, RV is normal systolic function. Then what is the abnormality? Dilated cardiomyopathy?
Is it ASD? Is it? No.
There's no ASD. This is the dropouts.
Okay.
This is a picture of mitral flow pattern.
Restrictive cardiomyopathy, sorry. E is taller.
What kind of a restrictive cardiomyopathy? Can you read up this first slide?
Sir, E wave is taller than the A wave. There is
A wave.
A is almost absent, sir.
There is no A wave seen over here.
Atrial fibrillation, sir.
Correct. Look at it over here. There is no A wave. Only E prime is there. 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 E prime is there.
Sir,
There is no A wave.
Sir, what is the wave after E? There is a in Doppler third picture. After E, there is a narrow thing.
This
Yes,
one?
sir. What is this? Yes, sir.
This is isovolumic contraction wave.
Okay, sir.
So this is a classical picture of
Atrial
atrial fibrillation.
Yes, sir.
All right. So we move to next person. Good attempt.
Thank you, sir.
Dr. Raghavendra. Are you there, Dr. Raghavendra? Dr. Prakash Raichur?
Yes, sir.
Tell me, Prakash, what is the abnormality in this patient?
Sir, there is a hypertrophy.
Hypertrophy of what?
Left ventricular hypertrophy is there, sir.
Okay. What else? You want to correlate with this image?
Thickened valve. Interior.
No. You cannot find a better picture than this, man. Believe my words. Dr. Niharika Tarhan. Dr. Niharika, are you there? Dr. Amit Kumar Singh. Dr. Ishwar Agarwal. All right. So 10 people have raised their hands. So Dr. Anuj, you would like to try?
Yes, sir.
Tell me.
Sir, septum and posterior wall is severely thickened. It is a hypertrophic cardiomyopathy, and during systole, it is obstructing the outflow, LVOT. So it is obstructive hypertrophic cardiomyopathy.
Good attempt, Anuj. So this is septum versus posterior wall hypertrophy. Septum is almost 2 times of posterior wall. Look, there's a turbulence in LVOT. It's better seen over here. And then there's associated MR.
Yes,
and
sir.
The most important thing is, look at this picture over here. This is systole, this is diastolic. So during systole, their anterior mitral valve leaflet SAM, which is present over here. And on top of that, LV function is hypertrophic. Very good attempt for, and this is a classical example for hypertrophic obstructive cardiomyopathy.
Okay, sir.
All right.
Sir, just one thing. So
Go
SAM
ahead.
is pathognomic for hypertrophic cardiomyopathy, right, sir? Without hypertrophic obstructive cardiomyopathy, SAM can be present sometimes also, other pathologies also, right, sir?
SAM can be present without hypertrophy. SAM can be present without
HOCM, right?
no. HOCM is what is hypertrophic obstructive cardiomyopathy. There are three features of hypertrophic obstructive cardiomyopathy. Septal posterior ratio is 1.5:1.
Yes, sir. Yes, sir.
Then systolic anti-motion of mitral leaflet and dynamic LVOT obstruction.
Yes, sir.
So if you have a SAM, then
Yes,
you have a dynamic LVOT obstruction associated with the MR and presence of septal posterior wall hypertrophy. Okay.
Okay. Yes, sir.
Anybody would like to attempt this question?
Is a mid cavity obstruction, sir.
Mid-cavity obstruction.
Excellent. Mahesh Pad Salge. Who answered this question?
Me, Dr. Mahesh, sir.
Dr. Mahesh, very
Yeah,
good
sir.
answer. This is the mid cavity
Yeah, turbulence is seen,
LVOT,
sir.
mid cavity obstruction.
Yeah.
Great. I think we are done. Let's see some more questions are there. No, we are done. So we virtually covered everything: restrictive, obstructive. So we have done almost all the questions as far as systolic and diastolic function is concerned.
Sir, the last image, sir, can I ask something?
Yeah, go ahead.
Sir, it looked like the mid cavity is there, sir, but the turbulent was higher, and the graph was showing.
I'm sorry, what did you say?
So the last image, which was last spotter, mid systolic obstruction.
Correct.
So the gradient was showing turbulent in nature because there was a
Gradient are insignificant.
but the the graph was showing not much of gradient.
Yeah, it's not there. Not much gradient are there. No doubt about it. Agreed.
Okay.
The gradients are not too large. The gradients are almost 16 millimeters of mercury, not more than that. Maximum 16. But this is definitely a mid-cavity obstruction. So, any other questions before I close down this session over here?